So good afternoon, everyone. I must apologize that I don't speak any Russian, but I will try to speak slowly in English so that you can understand the information that I'm giving you today. It's my pleasure to be here and share with you some of the really outstanding work that has been done through a multi-center trial. It took about 5 years to get this with multiple groups in the United States. And today I'm going to show you many of the results. So since its inception in the late 1960s, we've been doing prenatal studies for many, many years. In the early 1970s, amniocentesis was developed, and early studies that looked at its safety indicated that there was a risk of a procedural risk for miscarriage, which was estimated to be about 0.5% or about 1 in 200. When chorionic villus sampling was introduced in the early 1980s, again, there were big trials that were done looking at its safety, and they did find, again, a procedural related risk of miscarriage, which was estimated to be about 1 in 100 to about 1 in 200. For any of you who do perform these procedures, you'll know that the risk of miscarriage is certainly related to experience. And there are many, many experienced people that I've met throughout Europe and the United States that track their own statistics and report much, much lower risks of procedural related miscarriage. In the United States, it is the standard of care in obstetrics to offer either CVS, chorionic villus sampling, or amniocentesis to women that are at increased risk for having a fetus with a chromosome abnormality. And the American College of Obstetrics and Gynecology recommends that all women are offered prenatal assessment for aneuploidy either by screening or invasive diagnosis, irrespective of their age. What is the big difference when we talk about prenatal and pediatric or postnatal or adult studies? Well, there's a complete difference in the accuracy and the completeness of the phenotype. In pediatrics, you have a child in front of you. You can see they're dysmorphic, they have mental retardation, they have developmental disabilities. But in an ultrasound, you cannot see those types of things. So the phenotype has not yet presented itself. So there's a very big difference. There's obviously limitations of ultrasound. You can see in many circumstances fetal defects, but again, there are limitations of ultrasound, and in some cases you need to have the detection is dependent on the experience of the person performing the ultrasound. How people use the information in pediatrics, it's obviously going to be more for treatment or management, but in prenatal diagnosis, there are really two options. One is termination of pregnancy, but what we've actually come to see is that many people use this information to prepare themselves later on for either management and or treatment. So it should not really be seen only as a method for termination of the pregnancy, but what we've seen from the study is that many people do welcome that information for continuing the pregnancy and management in early fetal life or newborn life. And obviously the desires of the parents. There are some parents that want to know everything, and there are some parents that don't want to know anything. So this is kind of management from the the clinical side of the desires and needs of your patients. So this is kind of getting back to the question that was asked a little while ago. What does microarray add? And we've seen from many, many studies across multiple platforms, back arrays, then SNP arrays, and oligonucleotide arrays, array CGH, that when you perform microarray analysis in children that have a phenotype, you pick up about 15 to 20% of clinically recognized or clinically significant microdeletions or microduplications when you still see a normal karyotype. And all these studies over a course of about 7 years prompted the statement, a consensus statement, recommending that microarray analysis in pediatric case or for patients with multiple congenital abnormalities and developmental disabilities, that microarray should be the first test instead of karyotyping. In September of 2010, the American College of Medical Genetics kind of listened to that consensus statement and also re-emphasized that by recommending that karyotyping with chromosomal microarrays be the first diagnostic test that's performed. So that really led us it's going on about 6-7 years ago to start thinking about, well, if it's that good in pediatrics and adult studies, what's it going to look like in prenatal? And we didn't want to just go ahead and do it. We really wanted to get a very good study across the United States that assessed this in a scientific way by comparing karyotype to microarray and looking at the consistency and any incremental diagnostic power that you would get by doing it in a prenatal setting. For any of you that saw this actually led to, we finished this last year, and we wrote this up. It was in the New England Journal of Medicine in December 6th. And for a lot of the details, you can actually pull the paper there and look at it. But I'm going to highlight some of the key points in today's presentation. So there were about 31 clinical centers across the United States, and we approached just under 4,500 patients that were undergoing standard CVS or amniocentesis for standard indications. That the CVS was done as it usually was done, but we did ask the obstetricians for the amniocentesis to get an extra 10 ml or 10 cc's of amniotic fluid for the study. The karyotype was done by one central laboratory at Genzyme, and they would do routine cytogenetics, and they would also establish a backup culture. That was the karyotype result was reported back to the referring doctor, and that also went to a central data coordinating center at George Washington University. For the labs that were doing the microarray, the Genzyme sent about 7 cc's of amniotic fluid and about 2 to 4 milligrams of villi. That went to one of the 4 labs at Baylor, at my lab at Columbia, Emory, and Signature. And the microarray labs had no knowledge of the karyotype. That was all done in a blinded fashion. Once the result was ready, that was reported back not to the patient, but to the data coordinating center, who then took that and reported it back to the clinician. So there were 4,450 people consenting, 44 samples didn't meet the criteria, 15 weren't analyzed, leaving us with 4,391 samples for analysis. We had some 51 DNA extraction failures, so a total success rate of 98.8%. 58 mosaic cases, which were not reported in the New England Journal paper, but we are currently writing this up for publication, hopefully in the next 2 or 3 months, and details on that will be forthcoming. I'm going to concentrate really on the results over here. So we had a total of 4,282 non-mosaic cases where we had both karyotype and microarray, and all results were from uncultured samples whenever possible. Just to show you the indications, just under 50% were for advanced maternal age. About 20% were for a positive screen, like a nuchal or alpha-fetoprotein. About a quarter of them, 25%, had a structural ultrasound abnormality, and then any other type of family history, or because they were anxious, was for about 9.3%. There was pretty much half done by CVS and about half done by amniocentesis. As I said, we got a result in about 98.8% of cases. In most cases, for an uncultured amnio, We always got a result in about 83.3% of cases. When we didn't get a result, we went to the culture. And the same thing for uncultured villi. There was a higher success rate just on the direct sample. And any of those that failed on a direct, we then went to the culture. So that's why we have a total of about 98.8% success rate when you have both a direct and the possibility of a culture, if there's not enough material for a direct. You can see in the very beginning, even though all 4 labs had a lot of experience with postnatal and bloods, we did struggle a little bit with the DNA extraction in the very first 2 months of the study. And then we kind of all got together and worked on a protocol that once we got that established, then the DNA extraction success rate was very consistent. So the bottom line is we can see the accuracy between karyotype and microarray for non-mosaic cases was 100%. Here you see all the trisomies, and this was no surprise. We really expected that microarray is certainly going to pick up Down syndrome. It's going to pick up trisomy 18, 13, etc. For cases that we did not expect microarray to pick up, there were 40 cases of balanced structural rearrangements. And remember, microarray analysis will only pick up if there is an unbalanced form. So if there's a balanced rearrangement, you will not see it by microarray, and that is exactly what we expected. We would expect to pick up unbalanced rearrangements, and of all 22 were picked up by karyotype, were picked up by microarray. And marker chromosome, there were 3 of them. Only 2 of the 3 were picked up. One of them that was not picked up consisted only of heterochromatin, which is kind of the non-coding DNA, and there are no probes for that on the array. But that in of itself has a good prognosis, because if you find marker chromosomes historically that only contain heterochromatin and no euchromatin, then the prognosis is actually very good for the patient. Triploidy, you will not pick up triploidy by looking at the copy number aspect of a microarray. And what I didn't mention is in this study, there were 2 types of arrays that were done. One was using an Agilent 44,000 probe, and the other one was using the Affymetrix 6.0 array. Of the 17 cases that were identified with triploidy, 15 of them could be identified by using our maternal cell contamination studies. We did go back and look at all those cases run on a SNP array to see whether or not we would be able to pick up those triploid cases. And in fact, all cases, there were 5 of them, and all 5 cases easily could pick up the triploidy. It's very nice because Gareth and Pablo have already showed you all the allele tracks. So this should be very easy. They've showed you that it's broken up and plotted on the array or the allele frequency graph with A's at the top, the heterozygotes in the middle, and then the alternative homozygote at the bottom. And when you fill this in with actual data, that's what you get. So we get used to those 3 tracks when there are 2 chromosomes. And we know that, as they showed you, depending on the number of chromosomes, when there's 2 chromosomes, we see those 3 tracks. When there are 3 chromosomes, when there's a gain, we see 4 tracks. And there you see representing all the genotypes. And if there's a deletion, you can only be A or B. And it's very easy to see just by looking at the genotypes. So if you use array CGH, or even if you look at the copy number in CHAS, in the Affymetrix, because of the normalization process, you will not be able to detect triploidy. However, if you look at the allele frequency graph, you see their copy number is 2, so you will not see it there, but you need to look down at the allele frequency graph, and what you'll see will be 4 tracks for every single chromosome. So picking up triploidy in a prenatal specimen you will not miss it. It is very, very easy. And again, you'd know whether it's XXX because if you saw 4 tracks on the X chromosome, then you would know it was 69XXX. And if you saw 3 on the X representing 2 X chromosomes and 2 on the Y represent 1, you'd know it's 69XXY. So there were about 3,822 cases with normal karyotypes, and what we found was there were variants of unknown significance in about the 0.33 cases that were not reported. We did have a clinical advisory committee that when there was a finding of unknown significance that would meet, it was made up of obstetricians, geneticists, pediatricians, genetic counselors who would meet, look at the evidence of what the gene content was, what was known about that gain or loss, and then they would make a decision whether or not there was enough evidence to report back to the patients. So just under 1% of cases, they did not report it back. In 61 cases, they felt it was enough evidence to support that it was clinically significant. And then these were cases that were well known to be significant. If you break this up by the indication, for the advanced maternal age, we see about 1 in 60 cases that were referred for advanced maternal age or for a positive screen. Approximately 1 in 60 of them had a clinically significant copy number change. And if we change the focus to those with an ultrasound abnormality, we find out about 1 in 17 of them had a clinically significant copy number change. And I'll show you more details. So one of the things that's important is to realize that it's not all about Down syndrome. We see important findings by microarray that are not observed on the karyotype. And here are just some example of the micro deletion and duplication syndromes. These are some of the very common ones. And then you also see non-syndromic microdeletions and microduplications. The important thing is these are very similar, or these are the same types of abnormalities that have been reported in all the postnatal studies in the pediatric and adult cases. So we do see them in the prenatal stage as well. Structural anomalies, we do, once we see them, and then we do the array, it provides us with an opportunity for improved counseling. The array adds significant clinically information. As I said, about 1 in 17 or 6% of cases, we saw that had a normal karyotype, but a structural ultrasound abnormality, and 6% of them had a clinically significant copy number change. When you look at the literature of what's been reported in similar instances, you can see it's pretty consistent from the Fiorentino paper, from the Rosenfeld-Schaffer paper, and the Schwartz paper. All around about 6% show, the same type of thing. Here you see a structural heart defect on ultrasound. And one of the things that people have done in the past is say, okay, DeGeorge syndrome, and let's do the FISH for DeGeorge. But you have to remember that, number one, DeGeorge is a whole syndrome with multiple things. And cardiac only accounts for about 75%. So if you don't see a cardiac abnormality, you can still have DeGeorge syndrome. There are other factors that are involved in DeGeorge. And more importantly, all fetuses that have cardiac defects can have multiple, that can be caused by many other things other than DeGeorge syndrome or the 22q syndrome. And what you see is for all the cardiac defects that had a normal karyotype, about 210 of them, the number that had a normal karyotype with a microdeletion or microduplication syndrome was about 14.3%. But most importantly, 67% of those were not DeGeorge. They were something different. So if you saw a cardiac defect and you only did a FISH for DeGeorge, you would have missed 67% of these cases. Isolated cardiac defects, again, it's relatively simple, same, where about 63% of those that are found with a gain or loss, 63% of them are something other than 22q deletion syndrome. As I said, not everything is DeGeorge or 22q. All these types of syndromes have an association with cardiac defects. So when we see a cardiac defect on ultrasound, there are multiple other possibilities of uncovering clinically significant copy number changes. So just to see some of the instances, when you sum them all up, it gives you 6%, But very interesting. The additional benefit when you look at cardiac and the array findings. What was actually very interesting was renal. We saw about 11.6% with renal, and in some cases for specific types of renal anomalies, it was as high as 20 or 30% in likelihood when we saw those types of anomalies. The one nice thing is we're in the era now where sometimes we're going to see something on the microarray that's going to help us uncover a phenotype. And this was a very good example. As part of the study, there was a direct CVS that had a normal karyotype, and we found a deletion on chromosome 17. And when you look at this region, it contains the TCF2 gene, which is implicated in renal cyst and diabetes syndrome. And it's quite variable, but it can be quite significant. This was done, the CVS was done at about 11 weeks. The patient was asked to come back around about 17 to 18 weeks of gestation. The patient came back, they did a high-level ultrasound, and what you can see are the renal cysts that were evident on ultrasound. So this was a very good example of seeing the genetics first, bringing the patient back and actually finding the phenotype. We can't always rely on the phenotype. So ordering a selective microarray is not always possible. This is a patient that had a very mild club foot, which most of the time is just isolated and we're not concerned about. This patient happened to be part of the study, and what we did see was a 1.3 megabase gain on chromosome 7, which actually is associated with a very specific syndrome. We never would have thought about this syndrome just by looking at the ultrasound. And so you can't, the point that you'll see I'm making is our recommendation now following the study is that microarray is a good recommendation for all prenatal cases. Again, if we break this down, we saw about 1 in 60 of them from just age or positive screen had a clinically significant ultrasound copy number change. And in the United States, it's always been kind of the ideal to offer patients that have an increased risk, and that was defined traditionally as about 1 in 200. And so when you look at 1 in 60 compared to 1 in 200, that's a lot higher than that. So essentially, that means that everyone should have an array if you use those criteria. The other thing is this was actually very similar to another study that I did using arrays, which hopefully will publish in the next couple of months, where we also saw about 1 in 63 of them had a clinically significant copy number change in karyotypes that were normal. The other thing is that there are recurrent copy number changes that have the potential not only for structural abnormalities, but also for that are implicated in neurocognitive impairment, intellectual disability, autism, etc. And this occurred in about 1 in 125 cases. And these are cases that just came in for a regular low-risk indication. Here you see the recurrent types of neurocognitive phenotypes that were seen in our study, and this is, in the publication. The most common ones here you see were DeGeorge by far, and then some of the other ones. But what'll draw your attention is that the highest percentage was really a single occurrence copy number change, one that wasn't really recurrent, but that we saw involved many genes that were clinically significant and really isn't a recurrent finding. We did see cases that were of unknown significance. And as I said, we had a clinical advisory committee that met and used many different types of criteria to determine or make a decision as to whether this would be reported back to the patient. And you use multiple types of databases. You can also look at the gene content, and you also look to see whether it's inherited or de novo. One of the things that you'll see is we were asked just before the publication came out each lab director was asked to go back and reclassify some of the things that we had called earlier in the study. And so what you really see is in 2012, when we looked at those same cases, 2.5% of them we considered to be variants of unknown significance. From that time, so much more information was available in the databases that we were able to go back and say, okay, we can move this from unknown to about 1.5% of them became, so it dropped, only 1.5% of them became unknown. A lot of those now, we had a lot of information and reclassified them as pathogenic. So that went from 0.9% to about 1.7%. And we did also find that some of these are clearly benign with no type of clinical significance. So based on the increased detection of the relevant anomalies, as I said, our recommendation is that chromosomal microarray should be transitioned, just like in pediatric cases, to be the first tier test for invasive prenatal cytogenetic diagnosis. It detects all chromosome abnormalities or unbalanced chromosome abnormalities, so you wouldn't miss anything if it was unbalanced. Most of these copy number changes can be interpreted based on the gene content, the size, inheritance, and the various databases that are getting better and better every day. Counseling issues are not unique to prenatal. For many people talk about unknown significance, we heard about marker chromosomes, we've heard about balanced translocations. We've seen this in cytogenetics for many years. We've been dealing with uncertainty when we've seen these types of things. And so we've just changed the things that are uncertain, by dealing with microarrays. As we kind of make this transition into clinical practice, genetic counseling will be very important. Someone that has this information, has expertise and knowledge, is going to be very important for informing our patients. And we really, and this is happening all the time, need to improve the databases, and they are getting better and better. And I really think that very soon you're going to see a consensus statement coming out that says, that this should be standardly offered to all pregnant women. I'm going to switch gears now and spend the next 4 or 5 slides just telling you a little bit of the results from a very big stillbirth study. Stillbirth we define as fetal death at or after 20 weeks of gestation. It occurs in about 1 in 160 live births in the United States. The major challenges have been for chromosome analysis. It's been very difficult. Very often when we get a stillbirth, the fetus has been dead for many days. We get dead tissue and it's very hard to culture and to get a result. And, you get a long delay in either getting results back or getting results at all. Karyotype abnormalities are detected in about 6 to 13% of stillbirths that have successful karyotypes. So we know that a typical metaphase has about 400 to 500 bands per haplogenome. And at this stage of chromosome condensation, we'll detect deletions, duplications, really, I'd say 10 megabases. That's probably the best for stillbirth or products of conception studies. So given the suboptimal banding, it's unlikely that if you do karyotyping that you're going to see any gains and losses that are less than 10 megabases. So again, this study was presented actually in the same publication as the prenatal microarray study. It was actually back-to-back manuscripts that were published. We had 59 participating hospitals, about 953 women, for a total of 532 fetuses that had both karyotype and microarray. The study period was over 2 years, from 2006 to 2008, and it was really a very good population-based study. We performed at that stage the Affymetrix 6.0, that has 1.8 million probes. We analyzed this using CHAS, and copy number variants of 500 kb or larger were included in our analysis. Anything smaller was not included. So just to show you of the 532 results, this is now by karyotype. The failure rate was about 30%. Normal results were about just under 65%. Abnormal were about 6%. When we look at the array results, there you see we had just under 13% that failed. And look at that as a difference. Very significant. So the first important thing is our ability to get a result compared to karyotyping in stillbirth is significantly better. The about 74% were normal, and about 8.3% were abnormal. And again, that level was statistically significant, and the level of abnormality that could be picked up. The majority of those were in fact aneuploidies, and we did see pathogenic copy number changes in just over 2%. We did also see variants of unknown significance that accounted for about 5% of cases. So we also went back and said, okay, if the karyotype failed, what were the microarray results on those cases that failed? And here you'll see that about just under 75% of them were normal. We did see aneuploidy in about 4.5%, and we saw CNVs in about 1.3%, variants of unknown significance in 6%, and we did see cases that failed both karyotype and microarray, and that may have had to do a lot with the actual specimen itself. So what you actually see is that of the 157 patients that failed karyotype, patients could receive a result in about 86% of those cases. So that's a recovery of those patients that otherwise would not have received a result. For those that were normal by karyotype, the failure rate was about 12.5% by array, normal in the majority of those. We didn't expect to see aneuploidy because they were normal by karyotype. We did see some pathologic copy number changes as well as variants of unknown significance. Failure rate in the abnormals was 6.5%, 6.5% for normal, and copy number changes were 3.2%. So again, just to take it from the other side, we said for those that failed by karyotype, what did we see by those that failed by microarray? What did we see by karyotype? And we see that about 32% also failed, 64% were normal. Abnormal only accounted for 3%, and that's the same over here that we see over there. Oops. Actually, that's those that were normal. We saw failures in about 9%. 70% were normal. Actually, sorry, that's the abnormal. That's the same as that over there. And for those that were abnormal, about 20% failed by karyotype. 59% were also abnormal. We did expect that. 20.5% were normal. And of variance, we saw 40% failure, normal in about 56%, and abnormal in 4%. So the majority of cases are actually aneuploidies. We see the typical ones being trisomy 18, trisomy 21, monosomy X, trisomy 13. And this is consistent with what we've seen in the literature. We saw pathogenic or variants of unknown significance ranging in size from 584 kb to 25 megabases, and duplications from 500 kb to about 2.85 megabases. And one stillbirth had a pathogenic deletion and duplication that we interpreted as an unbalanced translocation. We did a subgroup analysis with those that had abnormalities on postmortem exam, and of those, there were 67 of them had structural anomalies. With the karyotype yielded results only in 67.2%, and 30% were abnormal. Microarray on the same, we saw again a much higher pickup rate, about 89%, and 28.3% had aneuploidy, 5% had pathogenic variants, and 5 unknown significance. So microarray analysis detected more abnormalities in the structural anomalies group than did karyotype analysis, and that was clinically significant. It represents a almost 54% increase, and anomalous stillbirths were significantly more likely than non-anomalous stillbirths to have an abnormal result on microarray analysis and karyotype, and that is really clinically significant. So I'm going to stop there, and I am happy to take any questions. Thanks very much.